Thanks again for joining us. What I want to do in this 40 minutes is give you an overview of the research that's going on in the field of sarcopenia, muscle loss with age, and then specifically give you some of the research and insights into the interventions that are being trialed and used clinically to slow it down. Now, here's my disclosures. Thanks to everyone on this list. And right, let's get going. So my conceptual model for how I think about my research program and how I think it's also useful for some clinicians and individuals to think about muscle health. We know that there is a host of factors that can contribute to muscle strength loss as we age. But when it comes down to preventing or maintaining muscle health, we're really left with only a few options. Now, pretty obvious. You can have physical exercise activity, pharmacologic support in clinical cases, but when it comes down to it, it's really nutrition, or specifically protein, that represents that fundamental element or the keystone that needs to be in place for any other intervention to work effectively or optimally. You can have the best exercise regime possible, best rehabilitation regime, but if you don't dial in the nutrition, protein support, you'll have a less than effective outcome. So that's how we've organized and arranged a lot of our research studies, focusing on the nutrition component first, and then supporting it, supplementing it with physical activity and pharmacologic support. All right, so protein, how much do we need? Does it differ depending on who you are and what circumstance you're in? Now, I'm sure that most of you are familiar with the concept of the RDA for protein. And most of you will be aware that in most countries, it's somewhat close to 0.8 grams of protein per kilogram of body weight each day. Now, while most people are familiar with that basic descriptor, not too many delve further and look for the nuance in the recommendation. If you do, you'll see a couple of subtle, important facts, and I've underlined them here. So the RDA, it's actually the minimum daily average intake of good quality protein that meets the requirements of just about all healthy individuals. So while the RDA is tremendously useful on a population level, when it comes down to a prescriptive individual level, it's less than effective. And one of the big problems I see, or obstacles, is this recommended. Truly is best viewed as a minimum. So if the RDA reflects a minimum amount of protein required each day, are there consequences of getting too much or too little? Now, if you look at this inverted bell curve, on the low range of protein consumption, the negative outcomes are pretty straightforward and they make sense. You don't eat enough protein, you're at risk of increased muscle loss, a loss of muscle function, your bone density can suffer, and importantly, you can have a reduced ability to respond to a crisis, illness, injury that we're going to talk about soon. Now, if consumption increases, you're eating tremendous amounts of protein, the risks are potentially there, but they're not as great. Now, we've generally dispelled the effects of too much protein on bone density or kidney function, but perhaps the true risk of consuming too much protein, a bit like too much anything, is you're going to exceed your energy requirements and gain fat. But as I hope you'll see during the presentation, we're really not recommending anywhere near a high extreme protein intake for just about anybody. We're really focusing much further on the left side, the moderate consumption of protein. All right, so how much do we need as individuals? Now, my lab and probably half a dozen other labs around the world can use this technique called stable isotope methodology. And basically, it's a sophisticated, powerful technique where we can obtain muscle biopsies from the leg of our volunteers and calculate the rate of muscle protein synthesis, which is a surrogate for muscle growth and repair. Now, this figure I'm going to show you here, we're looking at muscle protein synthesis, and we asked a very practical question. So instead of giving people isolated amino acids, we used a whole a whole protein food source. In this case, it was beef. So what we did was bring some younger, in this case, it was about 30-year-old, younger and older adults. The older adults were closer to 70. We brought them into the lab. We did the infusion of the stable isotopes. We took the muscle biopsies. And initially, we measured muscle protein synthesis while they were fasting. So that's all of us in the morning before you have breakfast, before you start moving around. Right away, you can see that it's kind of a good result for older adults. The red and the blue bars there on the left. When you're fasting, resting, there's no inherent decrement in your ability to slowly build, repair muscle compared to younger adults. That's encouraging. Now, the intervention in this case I mentioned was 30 grams of protein. That came in the form of about 4 ounces or 115 grams of beef. So just a single meal, only beef. And you can see we saw quite a robust 50% increase in the potential for muscle growth and repair. That's not a bad increase, but the standout here was that our young and older adults responded similarly. That's encouraging. And to me, that suggests that aging doesn't necessarily impair our ability to take actual protein-rich food and use it to build and repair muscle. All right. Now, we did a follow-up to this study. One, it was designed as a dose response. And two, we tried to mimic the large portions that we tend to eat when we go out to restaurants. So we gave our young and older volunteers, again, a 90-gram serving of protein, which is 12 ounces, quite a big portion. Thinking that 3 times as much protein, if we saw an increase in protein synthesis, that would be good. But obviously, we need to balance that with the extra energy, the calories, because a lot of societies are getting fatter. Here's the data. Now, sometimes in research, if you get a no difference result like this, it's disappointing. I don't think this is. I think what you're seeing here is a really powerful message of moderation. And to me, it suggests that somewhere around 30 grams of protein in a single meal represents a ceiling or close to the maximum amount of protein that you can consume in a single meal and effectively use it to build and repair muscle. Now, if you consume 90 grams of protein, you're not necessarily wasting all that additional protein, but the chances of it being used for muscle growth repair, as opposed to being ultimately turned into fat, increase. Now, just to complete this storyline, here's the data I just showed you. Fasting, we give you beef, nice increase in protein. If we got our volunteers to do just a simple bout of exercise, and in this case it was leg extension exercise, very similar to what you would do in a gym, wasn't particularly strenuous, 4 sets of 10 repetitions. When we got these volunteers to do the exercise close to when they consumed the protein meal, we saw a synergistic, or in this case, additive effect of protein plus exercise. Again, that's a nice increase, but the most important fact here was that the young and older adults responded similarly. So to have the ability to respond positively to both nutrition and exercise as we age is tremendously important. All right. Now let's talk. Let's go the other direction. Speak perhaps in clinical terms. Most researchers and clinicians would agree that if you've got a generally healthy population and you give them a decent meal of protein, they respond positively. Now, but what if you've got a group or an individual that can't or won't consume much protein? Now, say for a young healthy adult, if you take their meal and go from 30 grams of protein down to 15 grams in that single meal, a young healthy adult's ability to mount a muscle building response drops off proportionally. Half the protein, half the effect. Makes sense. That's fine. Here's the problem though. Healthy older adults, if you reduce the amount of protein, their response, their muscle building response, drops off precipitously. That's a problem, and this is what we call anabolic resistance. So you're resistant to the normal or typical stimulation provided by protein-rich meals. Now, this is nutrition research. So I think we should all try and put these data in the context of how we eat. And I think until fairly recently, and in some cases still, if you went to see a dietitian or a clinician and said, look, this morning I had a glass of milk, an egg, and some fruit. Most people would say, okay, there's 2 good quality proteins in there. You've got fruit, which is always good. Well done. But when you start to look at the actual gram amount of protein, a glass of milk might be 6 or 7 grams of protein, an egg, somewhat similar. So maybe you're getting about 14 grams of protein in that otherwise decent meal. 14 grams of protein for a young, healthy adult, not so bad. 14 grams for an older adult falls quite a way below that potential for maximally turning on protein synthesis. So there's a problem. All right, so a lot of these early acute studies led us to think about dietary patterns and how we consume protein over the course of a day, weeks, months. Now, this figure should be broadly familiar to a lot of us. And I think it's a truism that for a lot of cultures, breakfast tends to be a heavily carbohydrate-dominated meal. We tend to choose the breakfast cereals, the bread products, etc. So just as an example, this morning you may have had oatmeal porridge. Oats have a little bit of protein. If you add milk, that increases it a bit, but it's pretty hard to consume enough oatmeal to provide a robust amount of protein. So even if you had this otherwise great nutritious oatmeal breakfast, 10 grams of protein, which is about all you can get, is going to be quite a way below that maximum potential for building muscle. Now, we won't mention lunch specifically, but the other problem or opportunity is the evening meal, where a lot of us are consuming the bulk of our day's energy and calories in that single setting. So here's just a general example. In a lot of Western countries, we have 90 or more grams of protein available to us. We consume that much over the course of a day. And that changes depending on your age and sex, but that's not an unusual amount. But let's say your evening meal had 65 grams of protein. We know that in most cases, the body is effectively able to use about 30 for muscle building repair. So suddenly the usable amount of protein drops, okay? And the big problem here is that humans, we can consume as much carbohydrate and fat as we can put in, and we can store it for later use. Visibly, we store it. We can't do that with protein. So you can't over consume, just eat a tremendous amount of protein in a single meal and then effectively access and use those amino acids, that protein, later on that day for building muscle. So that anabolic window is really limited to that meal period of about 3 to 4 hours. All right. So in this context, I think we have an example of someone who might be overfed but undernourished. Here's the obvious next slide. Okay. So for just about anyone, we're not recommending adding extra protein into a diet. For most or a lot of populations, there's plenty of protein there. It's about being more thoughtful with what is available to us. So the concept here of evenly distributing protein is to get multiple meals throughout the day, starting with the traditional breakfast, lunch, dinner, where at each of those meals, you're getting closer to maximally or optimally stimulating protein synthesis, muscle growth and repair. Right? And we'd hope that over time, that would translate into the protection of muscle health. All right, now, thinking back to that last slide where there was oatmeal at breakfast, let's take it a little further. If you were a breakfast skipper, and we're not talking about intermittent fasting or purposeful caloric restriction, if you just habitually skip breakfast, or you just have a piece of toast and a coffee, all right? So this morning, if you did that, and you also went for a run, or you went to the gym, healthy adults, you're going to benefit from the exercise, regardless of what you ate, all right? But all of us, if we skipped breakfast and exercise, we probably missed an opportunity to get that additive synergistic effect I showed you earlier of protein plus exercise. All right, so for healthy adults, that's probably not such a big deal. But if we move into a clinical population where the exercise could be physiotherapy, rehabilitation exercise, and if there's no protein provided around the time of that activity, they probably missed one of the only opportunities that day to get a meaningful bump in muscle growth and repair. All right, so by adopting this basic concept, this framework where protein, amino acids are coming in throughout the day, it doesn't really matter when the activity occurs, or for that matter, what form of activity it is, cycling, weight training, yoga, doesn't really matter so much, but you've always got the potential for that synergy. That makes some sense. All right, so here's the actual study. And I should mention all of these graphs, you can see the reference at the bottom. These are all publicly available papers. Here's the study. We finished it a few years ago now. We did exactly what I showed you in the cartoon. One group, or both groups had the same total amount of protein and energy. We simply just distributed it differently. One group got 30 grams of protein at each meal, and the other group didn't have much at breakfast, got the bulk of it at dinner. And by simply manipulating that distribution, we found a 25% better muscle protein synthesis response over 24 hours in the even group. That's pretty robust. But again, we can't be misled by clean, nice-looking graphs. Important thing to remember here, we're not dealing with a diet that's going to give you a change in your body composition or your health in a matter of weeks or even months. This sort of dietary change is likely only to have an impact over months to years, long term. Okay, so we're talking about habitual practices, changing them slightly and seeing health benefits. And we're going to talk about sarcopenia, and you'll see how these subtle changes over each day could potentially lead to better health in the longer term. Sarcopenia. Now, I'm sure most of you are familiar with it. We're seeing a lot of mention in the lay press, in the media. Now, there's lots of groups around the world trying to refine the definition, how to test someone for sarcopenia. And while there's slight differences in how different groups characterize it, there are also some similarities. So in general, when someone's giving you a definition, most people will say that sarcopenia is a progressive, insidious loss of muscle. It starts somewhere in your 40s, give or take. And typically, it's about 1% or less loss of muscle mass per year. So it's really a slow, gradual reduction in muscle mass. And importantly, it's also associated with a reduction in function, muscle strength, endurance. So during the early onset of sarcopenia, these subtle changes in muscle and strength, you can make up for it with lifestyle adaptations. It's not till later where it becomes physically consequential. So that's the basic definition. And again, most times when people talk about sarcopenia, they'll show you a slide like this, showing the gradual 1% per year reduction in muscle. This isn't terribly useful beyond describing a large population of people. All right. So if you're a clinician and you're interested in reducing the severity of sarcopenia, and this is the model that you think of, really the only option here is to try and flatten that curve a little and reduce the rate of loss. But I'm sure most of you are aware, this doesn't happen to anyone. No one sort of sails through life with this pattern. That would be probably boring. This is what happens to most of us. Okay, and I think it's realistic. It's a problem, but it's also a tremendous opportunity for intervention. So basically what happens, catabolic crises. So you might be aging perfectly well. Maybe you're losing a little bit of muscle in your mid-40s, 50s, but then you might go skiing and tear some knee ligaments and you put in hospital. And it's during these pretty brief periods of hospitalization, physical inactivity, inflammation, etc., where you can lose tremendous amounts of muscle and muscle function and perhaps have incomplete recovery, and then you're back on a regular trajectory. But these episodes of crisis over time can turn a healthy 40-year-old into a sarcopenic, frail 80-year-old. Right, so they're causing a lot of issue, but if we target these brief periods, which can be as short as a few days, we have the opportunity to really benefit muscle health as we age. All right, now this is a little bit of an embarrassing slide. The study was performed in our hospital in Texas, and I think if any hospital clinic did the same sort of study, you'd see similar results, unfortunately. So what we did was go into our acute care for elders unit, a special ward where all the inpatients are over 70 years of age, and and most of them had community-acquired pneumonia. We simply put pedometers, accelerometers, on these patients, and we measured how active were they, how many steps a day were they taking. And the embarrassing thing was in the black bar here, 95% of the time that these folks were in the hospital, they were completely physically inactive. So just about the entire day, they're just lying in bed, 0 steps per minute. The period of time when they weren't immobile, they were just taking 15 steps a minute. So they're shuffling to the bathroom or perhaps getting physiotherapy or some sort of treatment. Right. So in our patient population, we have a bed rest model of disuse. So that led us to this platform of using bed rest to mimic the physical inactivity experienced by our patients. And the nice thing about this bed rest model in a research setting is that, yeah, we can mimic what happens to our patients, but we can also separate out the myriad of disease-related effects. So all of our patients have some sort of version of a catabolic disease status or injury, okay, and it complicates research studies. So with bed rest, we can just look at the effects of disuse on skeletal muscle in the traditional reductionist approach. So here's a few studies just to impact and drive home the consequences of just disuse, inactivity on muscle. Now, some of these studies were NASA supported. We use bed rest to mimic what happens if we send people into space where there's no gravity loading. So this young cohort, this was a NASA study. We put them on bed rest for 28 days, which is a dreadful thing to do to someone. And for all of these studies, we carefully controlled their diets. So they all received about 1 gram protein per kilo body weight. So a decent amount of protein. Now the measurement here was a DEXA scan, similar to what you would use for bone density, osteoporosis. It can also measure muscle and fat. So these young, healthy adults on bed rest for a month, they lost almost half a kilogram of muscle just from the legs. So this is a scan from the hips down. That's a decent amount of tissue, but they're not particularly at risk. So to make it more clinically relevant, we recruited a group of older adults and we put them on bed rest for 10 days, which might be similar to a typical length of stay. Now here's the data. This was frightening. You know, in effectively 1/3 the time that they were inactive, they lost 2 to 3 times as much muscle mass. All right, so really problematic. Now, just to complete this picture, middle-aged adults tend to be a neglected research demographic. Okay, we tend to just recruit younger and older populations. So we recently finished a study with middle-aged adults. Now these individuals, and it was men and women in each group, these individuals were 50 years of age. And before the bed rest intervention, they looked just like their younger counterparts. So they had the same muscle strength, same endurance, no impairment at all. So we honestly thought that putting them on bed rest, they would fall somewhere in between. But there's no good news with this, okay? These healthy middle-aged adults lost muscle just as quickly as their parents would have. So I struggle to find good news with that, but perhaps we can piggyback on a lot of the messaging around osteoporosis. So we know that protecting bone health is something we need to concentrate on in our younger adult life. I don't see any difference with muscle. All right. Now, a couple of points here. To qualify for a lot of these research studies with muscle biopsies and infusions, it's a complicated study. So the volunteers have to meet screening criteria, which are stringent. So these are healthy research participants. So it absolutely doesn't reflect the broader population. None of our participants had insulin resistant. They were all normal body weight. So this shows you what happens in the best case, and certainly not the worst or typical case. So just as an example of that, I took some of our patients again, and I did a DEXA scan on admission to hospital, and 3 or 4 days later when they were discharged. And again, most had pneumonia. In just 3 to 4 days, a patient population who's bedridden in a hospital bed, I'll show you what they eat, and they also have inflammation, cytokines causing increased muscle loss. All right. Now, for the healthy older adults, a kilogram of muscle from the legs represents about 10% of their total leg mass. For these patients who were more compromised to begin with, that can represent upwards of 15% of their total leg mass. Super hard to recover from. All right, so what are they eating? Here's a very simple tray plate analysis and plate waste study. So what we did was simply do an analysis of the different meals that were being presented to our patients. And if we just focus on protein and the black bar, what is being presented, we can see that in pretty much every meal that's being presented, there was a lot of protein on each plate. And that didn't matter so much whether it was mechanical soft or low sodium. Each tray had about 40 grams of protein. The problem was that on average, our patients were consuming a fraction of that, less than 10 grams. Now, as I showed you before, 10 grams of protein for a healthy older adult falls quite a way below that optimum. All right, 10 grams for someone who's bedridden and has got inflammation, disease going on, it's minimal. And it's complicated by the fact that about half the protein that our patients were consuming came from meals like this. Now, if any of you volunteered for a bed rest study, within 3 or 4 days, you start to become insulin resistant. So if you're already insulin resistant or even type 2 diabetic, and you remove physical activity, you move the ability of muscle to easily take up glucose from the blood, and then your diet contains these sugar bombs, it's a recipe for metabolic dysregulation. You've got to eat something, but that's a dreadful thing to do to yourself. All right, just quickly delving into some of the nuance with these data. These are just comparing men and women. So if we look at middle-aged men and women, you can see that a 50-year-old man tends to have a more negative response to disuse compared to a similarly aged female. So a 50-year-old female still has a more youthful response to disuse. That's encouraging, but here's the problem. Once we move from about 50 years of age to 70, if you look at the male population in blue, by the time you're 50, you're at maximum risk, if you like. Increasing age doesn't increase the muscle that you'll lose. But if you look at the female response, a 70-year-old female loses dramatically more muscle and strength compared to a younger version of herself, and even more than a similarly aged man. Right, so there's a lot of research going on now to try and understand what is this sex difference, how is menopause triggering or related to it, and what can we do to specifically target these at-risk women. And on a similar point, we know that there's people amongst us who can look at a piece of cake and put on fat. There's some of us can look at a barbell and put on muscle. There's also responders and non-responders, if you'd like, to inactivity. These are just the middle-aged men from one of our studies, 14 days of bed rest. You can see at the top in the blue, some of these men, if you put them on bed rest, they really didn't lose too much muscle at all, non-responders, if you like. But down the bottom in the red, there's an equal number of individuals who lost tremendous, absurd almost, amounts of muscle. And again, one of the challenges for research and clinicians is identifying why are these people at greater or lesser risk, and can we identify them early in, say, a hospitalized period to try and reduce this 2 kilograms of muscle from the legs is absurd. Okay, they're definitely at risk. But right now, we don't know why that occurs. So watch this space. All right, so I've set a pretty grim picture so far. And I mentioned at the start, our approach to interventions has really focused on the pragmatic and practical, with nutrition being that keystone. In a hospital setting, we have to feed everyone, but there's a cost and a risk to exercising, and drugs aren't something, testosterone, etc., aren't universally recommended. So one of the main nutrition elements that we've looked at recently is the branched chain amino acid leucine. So it functions as one of the building blocks of protein, but it's unique in that it serves as a trigger, if you like, or a switch that turns on the muscle building process. And you can delve into the molecular pathways, how it turns on mTOR, starts translation initiation. But one of the benefits of leucine is that you can find decent amounts of it in common high quality foods, and I'll give you a list in just a moment. Now, I think just as not a warning, but just a note that a lot of times when researchers come up with a positive study on a nutrition ingredient or an element, people are in a quick rush to sell it. I think in the case of leucine, the benefits are probably overstated for healthy adults. So if you're healthy, you're eating a generally good diet and you're exercising, you don't need a whole lot of leucine, right? But if you're compromised, hospitalized, or perhaps trying to win that the gold medal in a sporting event, it's those both ends of that bell curve where leucine could be beneficial. And it seems to get the benefits of leucine, you need to hit a threshold, or approximately 3 grams of leucine per meal. Now that's not a lot, but fortunately you can find it in everyday foods. So, for example, whey protein is got the highest abundance of leucine, but you can find it in about 115 grams of beef, for example. You'll find 3 grams of leucine. In one of the scoops, little plastic tub scoops that come with a lot of whey protein supplements, you'll probably get more than 3 grams of leucine. All right, so let's see how it works. This is the middle-aged group that I showed you just before. And in this research model, we simply added 4 grams of leucine to breakfast, lunch, and dinner of our volunteers compared to a alanine placebo. And if we just look at muscle function, if we measure muscle endurance, so that's putting you on the leg extension machine and doing repetitions and tracking fatigue curves, about 20 repetitions. The blue was the typical expected loss that we saw in the control group. But the orange, leucine, seemed to have this partial protective effect of muscle endurance. If we put our volunteers on a bicycle and did a VO2 max, measuring aerobic endurance, again, we saw a protective effect of just supplementing with leucine. And for any muscle strength outcome, again, the blue, that's the typical loss of strength with inactivity. But again, we're seeing this partial protective effect. And notably, if you compare this sort of effect with something like testosterone, it's actually more robust, which is remarkable. Now, here's the rest of the story, muscle mass again. So on day 7, we did the DEXA scan, and you can see that our control group had lost pretty much all the muscle that they were going to in the first week of inactivity. But like the function, providing leucine seemed to be partially protecting muscle mass as well. Super encouraging. But if we looked at the second week of inactivity, the bed rest group, the leucine group lost just as much muscle. as the control group. All right. Now that's important because I think it's impractical to think that something like protein or leucine has the potential to chronically protect muscle health. So if you're chronically disabled, hemiplegic stroke, you're on bed rest long term, leucine's not going to be ultimately effective. But if you're hospitalized for a brief period of time, 7 days, maybe shorter, that's pretty typical for most of us when we're hospitalized or sick. Leucine may have a role. Now here's the chart with the different sources of leucine. As I mentioned, you don't have to buy the supplements. Okay, you can find it in most common food sources. Notably, some of the protein sources like collagen don't have a lot, but the milk proteins, whey protein in particular, are quite rich in it. Now, those leucine studies led us to do a whey protein study based on some practical concerns. So leucine, you can add a small amount and have a robust response, but it tastes dreadful and it's quite expensive. Okay, so we wanted in our clinical populations to come up with an alternative that was perhaps more available, more practical, and in the case of whey protein, which comes in chocolate flavor, tastes better. So in this, again, another bed rest study, 7 days of bed rest, you can see the details here, 20 people, healthy older adults. In this case, we put them on a slightly calorically restricted diet, hypocaloric, if you like, because that's what people tend to eat. We don't eat that much if we're hospitalized. And instead of just supplementing or adding whey protein, we used whey protein as kind of the leucine delivery vehicle. So we didn't add extra whey protein. We simply replaced the protein that was part of their regular diet with whey. So subtly, we were increasing the quality of the diet that these folks were consuming. All right, and just one of the outcomes, the orange group there is this is fat mass. So one of the benefits of the whey protein is that it increased the loss of fat mass, and if you look down the bottom in the text, while also protecting muscle. So again, I think there's a lot of potential for individuals who may be overweight, hospitalized, wanting to protect muscle mass, but also not wanting to increase fat mass, which is one of the issues if you just force extra food onto someone. All right, so just in the end here to give some summary recommendations, I think we can split this into prevention and treatment options. And we can get into a lot of specific details about prevention, grams of protein, which molecular pathways being triggered, etc. But as a starting point for most people, a broader framework is more effective. So I'd suggest that for healthy adults on a day-to-day basis, you can recommend establishing a dietary framework that includes a moderate amount of high-quality protein at each meal. That's an effective starting point to prevent the sarcopenic loss of muscle. But that's vague too. So you absolutely have to modify this suggestion based on the individual needs. Yeah, what are your energy requirements? If you're a 120 kilogram athlete, you're going to need a lot more protein than a 50 kilogram hospital patient. Okay, 30 grams of protein for that athlete is going to be a snack. 30 grams of protein for someone who's tiny is a huge meal, right? But the concept of moderate applies to both. So there's some other factors that you can modify this prevention strategy accordingly. Here's the area that I think we can have the greatest immediate impact. All right, so it's focusing on these periods of catabolic crisis. So if you're injured, ill, physically inactive for a period of time. Key points: middle-aged adults and older adults are at increased risk of muscle. All right, just consuming the RDA for protein is by no way near enough. All right, but by simply adding extra protein, that's also inefficient. Okay, the key area here is, I think, if you could react aggressively with targeted nutrition support, which could be something like a high quality whey protein or leucine, and then add in physical activity, drug support, I think by really focusing on these short periods of time, we can ultimately have the biggest potential benefit. So with that, thank you so much again for joining us. Apologies for the slow start, and I'd be delighted to address any questions that I can. Thank you.